Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more.
Hello everybody, we are the Millennial Mechanical Therapists. I'm Joe.
I'm Clay.
And today we have a special dual combo video on MDT and how it fits in the current kind of dogmatic conversation going on in our field right now of being more pathoanatomic minded versus a non-pathoanatomic center of thought. So I personally think that MDT, although founded a long time ago, in an era where everyone was trying to explain everything they were doing in the body with research on, anatomy, pathoanatomics, what's going on,
things like that,
biomechanically, and although that was where it was born, I think, well ahead of its time, it's deeply centered in a non-pathoanatomic way to treat patients, a way to think about how to treat your patients. And I think it fits really well in this conversation that we're having now. And that was, 50 odd years ago when it started. So interesting that we're having a conversation about it now. I think it fairly sits dead center-ish in the middle or even off to the side of being a little bit more non-pathoanatomic than it does in the anatomic world, although those definitions, the old school definitions have been rooted, I guess you could say, in the pathoanatomic mindset. I know you have some interesting thoughts on that as well.
Well, I think that all kind of stems back to the idea in the stereotype that MDT is synonymous with intervertebral disc, especially intervertebral disc pathology. You and I have both been accused in the lumbar thoracic or cervical spine of moving a disc, getting the disc off the nerve, those things like that.
Yeah.
And I genuinely don't think about it that way. As I go through my exam, I'm not going, oh, let's do this and move the disc off. It doesn't enter my mind because what I do look for is the symptomatic and the mechanical change in my patient. Now, we use that word mechanical to mean their movements, not necessarily the biomechanics of it. Is this having a better roll and glide? Maybe, after doing it a bunch, probably, I guess. The neurons are probably a little bit more efficient at that point, but as we do that, we go 10 of these or something, and then all of a sudden they rotate way better. That's the mechanics we're talking about. That's why we kind of call ourselves the Millennial Mechanical Therapists, because we're looking at those mechanical changes, not necessarily the biomechanics within somebody's pathology or something like that. So I know that has been a little bit more frowned upon, the whole disc model thing, in the recent courses I've taken. Is that what you found too?
Yeah, no, I mean, no one's truly even speaking on it as much as they did. And I've even heard some of the older diplomats speak on how Robin truly didn't want to have his way of thinking or his conceptual thought process be based on the disc model, but at the time there was a need for some sort of pathoanatomical
that was the era.
There was some need for some definition or something to blame or something to put your finger on. So when he was forming the institute, trying to actually teach more people about his school of thought, and his way to attack these musculoskeletal problems, they kind of were cornered into doing that, which is unfortunate because now it seems that the institute, those of us who practice this way, as we're moving into this era where we're moving away from pathoanatomics, almost,
pendulum swinging all the way to that direction right now.
Yeah, totally away from it. That we have to backtrack a little bit and kind of defend ourselves. Yet I feel like, truly MDT for the past 50 odd years is well ahead of its time, looking more at, just mechanical, like we said before, the ability to move, not the biomechanics of it, or not the more pathoanatomical variations of it, for the mechanical changes, the symptomatic changes you can make on an individual when you move them, when you follow their response, the patient-generated response, which I think is awesome. But now we have to kind of defend ourselves because of it. which is weird though, because I feel like if you truly paid attention, yes, there's some definitions, some terms, some things that are just very old school and kind of just, I think, maybe just be stuck in the system, because it truly is more of a historical relation back to when Robin was making this and thinking about this, which is fine. But if you understand the system, if you understand how to think, because truly MDT is not a tool, it's a mindset, and I think we've talked about this before. It's a thought process. So if you have the thought process of patient-generated responses and looking for a direction of preference or direction of vulnerabilities, things of that nature, then it doesn't really matter what you think of the pathoanatomics at the time, because you follow what makes the patient better.
Yeah, who cares about the biomechanics at that point? The intention of repeated extensions is not to improve the roll and glide in that direction necessarily. Mm-hmm. Maybe that is a byproduct that now, with the pendulum swinging so far, we're just not paying attention to. Yeah. Maybe, I don't know. But I can say with certainty, when the patient feels better and they centralize with that, you're going in the right direction. All the research points to that. Yeah. That centralization, if you achieve that or you see that phenomenon happen, you're going the right way. Yeah. So with all of that in consideration, have you seen a case personally that the anatomy just defies everything that goes on with symptoms and mechanics?
I've had a few cases that have really just been kind of eye-opening or a little different, to the point where one which is kind of scary, which I'll share, is I had an individual with a positive finding of spondylolisthesis. It wasn't a huge slippage forward. I don't think it was a grade 3. I think it was more of a grade 1. So this individual was not, was not in a state where maybe he was unstable or anything like that.
No
or
dire
at least
need
to some
for something
degree.
quick.
Yes. And he came in with just local low back pain. I had a previous therapist was treating him. He wasn't getting any better. They were doing a lot of flexion-based activities, and he put him on my schedule because he knew that I wouldn't be afraid to move the individual. And I've seen people with a history of a spondylolysis or anything of the nature that have responded to extension. So I did with this gentleman like I would do with anyone. I started from patient-generated forces and moved on up, and lo and behold, repeated extension with clinician overpressure.
Ballsy.
Yeah. Abolished his symptoms. Now, by himself, he was able to decrease no better. So if you follow the protocol, or if you've listened or taken any McKenzie courses, you're in an amber situation, the yellow light. You can either add force, add repetitions, but if you're not, decreasing pain and then it comes back, I couldn't see how I was doing harm to the individual. So when I put a little bit of pressure into his low back, and all of his pain went away. And his this was a while ago, so I truly don't remember some of the mechanical responses that we saw, but range of motion increased. He felt better. He got off the table and walked around and felt better.
That's awesome.
I mean, my colleague who was working with him was afraid to do anything but flexion because of the anatomical label of a spondylolisthesis.
Consideration there, yeah.
And that's a serious. I mean, those are legitimate, findings. Those are legitimate diagnoses.
If anything is actually pathoanatomical,
it's a spondylolisthesis, right?
Your fracture just floating there should be pathoanatomical.
But every time he did this, his pain went away, and within about 2 weeks of being on my schedule, we went through the recovery of function, and he was totally fine. And he swears by MDT.
That's awesome.
He swears because I wasn't afraid to move the individual. I wasn't afraid to put my hands on him because his body, his symptomatic responses, his mechanical responses were saying it's okay. Now, was I a little bit more ginger with him than I am with most? Heck yes. I think I would be...
Anybody would be a little gun shy.
Yeah, seriously. So, and I've spoken to him in the past year. He actually follows up with me all the time, which is pretty nice.
That's awesome.
He lives in my hometown, and he's doing great. So, which is wonderful. But here's a situation where something that can be relatively scary for any clinician to mess around with, for any patient to mess around with, and he's failing traditional care. I just wasn't afraid to move him and listen to his body.
Yeah.
Pathoanatomics made no sense, but symptom response, mechanical response did, so full speed ahead.
And it's so important to listen to those factors. When you're telling that story, it reminded me of a patient that I had. It was localized right-sided low back pain. So it pretty much just sat square above her right buttock. Didn't go down, didn't go anywhere, but it just sat right there. And it was a moderate amount of pain. She was not happy coming in. That story, you know. So I go through the repeated movement assessment, and this is a little bit early in my career. So I was thinking a little bit more pathoanatomically from school, things like that. And I had this idea in my head, well, extension didn't hurt much. I think it was a produce no worse situation. And as we went through, we continued the force progression through extension, and we got nowhere in terms of directional preference or centralization. So what I do, thinking a little bit pathoanatomical, I try to close down the side of pain, because that's what we're always taught. The idea, I suppose, is you squeeze more of the disc back in. That way you focal point where your pressure is.
Yeah.
So I have her go over that way, and she just hates me. She gets so much worse. Her mechanics look worse. Her symptoms look worse, or symptoms feel worse. So I go, okay. Now this is a little early in my career, so I bail and I try some other things. I try pure frontal movements, side glides, things like that, and I cannot affect this thing. Finally, I get to the end of it, and I go, you know what? Lie back down. I have her lie down. I move her hips away to the other side. So now I'm opening that side, which, from past pathoanatomical thoughts, we're going to squeeze that disc further out more and cause more of a herniation, supposedly. So I have her over there. I have her do extension with her hips offset to the right. Again, opening, gapping that side. She starts feeling a little bit better. Nothing crazy, but a little bit better. And okay, let's chase this down. I have her do more. She went through about 50 of them, and she got decreased, no better. So she felt better, but didn't stay that way. I come in and I give her the frontal plane overpressure, one hand on the hip, one hand on ribs, give her that. I'm just squirting this disc out, supposedly.
So
this thing's coming out her butt soon. And all of a sudden, she gets up and goes, I don't have pain.
That's awesome.
Yeah.
That is awesome.
What do I explain?
I explain that.
Symptoms mechanics have to trump that pathoanatomical mindset sometimes.
100%.
So, those examples are kind of a big takeaway for this video in terms of you can't rely on one or the other, I don't think, but listening to what your patient truly says is going to guide you. And that was something we referenced, I think, in our first videos.
Yeah.
Sirius said that. If you listen enough, your patient's going to tell you what's wrong, and they're going to tell you how to fix them. I don't care if you do it through pain science, if you do it through Graston, if you do it through MDT. I don't really care. But as long as they get better and you're doing it in a way that's going to empower them, that's what's important.
Yeah. It's putting the patient first. I mean, regardless of how you explain it to them, I think, it's funny, we get so wrapped up in trying to explain what we do. I feel like we're always trying to back up what we do so much because we're so afraid to be called out on what we do.
Just a classic example of losing the forest for the trees.
100%. We get lost in the fact that your patient doesn't give a crap if you call it a derangement versus arthritis versus stabilization you need versus XYZ. It doesn't matter to them. If it makes sense to them and they're getting better, that's all they care.
Yeah.
Right? So if you have the ability to explain multiple things, I would think it's the best way. Be able to explain multiple things. I think we've all had the patient who's come in and no matter what you say, she's definitely intent, or he is definitely intent that it's the arthritis in whatever joint. And you couldn't tell her whatever because mom's had arthritis, dad's had arthritis, the doctor said it's arthritis, she knows it's arthritis, so it's arthritis. Do you sit there and argue with that patient and tell them that it's their brain? Or that it's the meniscus in her knee, or a fat pad in her elbow? Does it matter? Blame the arthritis. If she's going to believe it, then that's what's going to work.
Right.
I mean, patient belief has shown itself to be beyond that of most things that we can even say that we do. Patient belief is shown to be better than most medical treatments, even outside of our profession. So work with what the patient gives you. You know what I mean? If you have to explain it in a pathoanatomical way, so be it. As long as your mindset is how to clinically reason through these problems, it doesn't matter how you use it. For us, MDT seemed to stick. MDT seemed to help us kind of blend some of the pathoanatomics with this wide area of being like, it doesn't matter that you have a diagnosis of stenosis and extension abolishes your pain because your pain's going away. So I think, the take home from a lot of this is, yes, MDT was born in the era of pathoanatomics, and there's still some of that ancestry left over.
I think it should be too.
Yeah.
I mean, we can't just forget it.
No.
But it might not have as big of a role as thought then.
As what we blamed it on.
Mm-hmm.
So, and no, I agree with you. Like you said earlier, the pendulum has gone so far one way. Just as before no one even wanted to talk about the connection between the nervous system and the musculoskeletal system. But now everyone's talking about it. And I think it's wonderful. Let's explore it. Let's see what we can do. But let's not forget our past, right? Because we're bound to make the same mistake in the opposite direction if we do.
Right. As soon as you lose that forest and go down that path, then blinders set in, and it's real easy to have a problem.
It is.
So,
awesome. Well, hey, my friends, thank you for joining us again. I hope you enjoyed this video. Leave us comments. Check us out on Facebook. Subscribe to our YouTube channel. Go to our website. We always have interesting articles up there. New research that we can find. Throw links up there for you. We're trying to get more and more of the patient caseload information up so you guys can kind of reflect and look back. Let us know what you think. We hope you learned something. As we say, always at the end, move your patients early.
move them often.
And move them to end range, my friends, because that's where the magic happens. See you till next time.
See you later, guys.